Hi, my name is Joe Cruitt, and today I'm going to be doing my autoimmune disease report on psoriasis. So, first, I'd like to start off with some characteristics of the disease. It is a chronic systemic autoimmune disorder, which is characterized by the formation of skin plaques, which are scaly and red and itchy and sometimes very painful. They usually present themselves, as you can see in these pictures, on the hands, on the scalp, elbows, also knees, sometimes under the arm, genital area, and the abdomen. So, really all over. This is a debilitating disease, so it is non lethal. It is associated with various comorbidities, so it can technically cause disease that way, but psoriasis usually is non lethal. It's characterized also by T cells, which attack keratinocytes, causing hyperproliferation, so just making them produce more cells than they would normally. Some other theories, so the mechanism to psoriasis is decently unknown. There's still a lot of research going on about that. So some other theories are that it's a genetic disease. So one piece of evidence which corroborates this is that monozygotic twins, so identical twins, if one twin in a set of identical twins has psoriasis, the other twin is 3 times more likely to develop psoriasis, whereas that is not the case with dizygotic twins or non-identical twins. It's also thought that it's triggered by various nonspecific triggers, such as certain drugs, for example, antimalarials or beta blockers can trigger psoriasis, or infections, such as infections with strep can cause psoriasis, or different like itching or scratching or getting tattoos sometimes can cause psoriasis. So first, I'd like to start a little bit into the history of psoriasis. I have a few slides on this. I thought it was super interesting, but I understand if you get a little bit bored. So starting where most medicine starts, we're going to start with Hippocrates, the father of medicine. He first describes skin disorders using words like psora and lopoi, psora meaning itch and lopoi meaning scaly or dry. He described various skin disorders like this. Some of them we think were psoriasis. The next person was a Roman official, Cornelius Cellus, which you probably can't really see because he's behind my picture. But he describes a skin condition which affects limbs and nails, which is characterized by red skin covered in scales. So this sounds a lot like psoriasis. And also Galen of Pergamon, he was the first one to use the term psoriasis to describe these itchy scaly eruptions, which he observed on eyelids and genitals of his patients. And lastly, during this time, psoriasis and leprosy were often lumped together. There wasn't a very clear distinction between the two. And also during the next period we're going to be in the Middle Ages, leprosy and psoriasis were often lumped together to the point where it actually became a problem. So all of these people were with these skin conditions, like psoriasis, were grouped in with lepers, who obviously we know were outcasts. They were forced to carry a bell and clapper to sort of like announce their presence. And unfortunately, Philip the Fair of France had a lot of lepers burned at the stake alive, just to keep away the uncleanness. And since there wasn't a very clear distinction between people with psoriasis and people with leprosy at this time, unfortunately, a lot of people with psoriasis were also burned at the stake, so it was not a great time to have psoriasis. After this, however, the age of the Renaissance, there was a lot of research being done, especially on skin diseases. Girolamo Mercuriali writes De Morbis Cutaneis, which describes psoriasis as lepra Grecorum. As we're going to see in a little bit, describing psoriasis as lepra Grecorum is a little bit problematic because this means that people see lepra and they still associate it with leprosy, which it is not. And then moving on, also in the Renaissance, Bernardo Ramazzini writes De Morbis Artificium Diatribe, And this describes skin conditions such as eczema, dermatitis, and also psoriasis. And then moving on to when psoriasis was actually distinguished as a separate disease from leprosy in the 18th and 19th centuries. Daniel Turner, Charles Laurie, John Van Planck write generally about skin disease. They include psoriasis a little bit, but there's not a clear distinction yet until the 19th century, when Robert Willen sort of classifies different skin diseases. He recognizes psoriasis as separate from other skin diseases, specifically leprosy, but unfortunately, he still terms psoriasis as lepra vulgaris. So people still are sort of associate psoriasis with leprosy, which is still problematic. And it's not until Ferdinand von Hebra where he removes lepra from the description of psoriasis. And this is when we really see a clear distinction between the disease. And so as you can see in the pictures on the right, leprosy and psoriasis are very similar. The picture on top is psoriasis, and the picture on the bottom is leprosy. So it's understandable where some of the confusion comes from. So a little bit about incidence, starting off with worldwide prevalence. It's not super prevalent, thankfully, but also remember this is on the worldwide scale. So it's 0 to 2.1% in children, but just realize that's out of the whole population. So that's still many children, and it's 0.91% to 8.5% in adults. In the United States, there's very low prevalence with a 0.0408% in children and a 0.0789% in adults. And mortality from severe psoriasis is about 8.92. But take into account that the study I was looking at, which looked at the mortality of psoriasis, was only looking at severe psoriasis. So that 8.92% isn't mortality out of all people with psoriasis. It's only mortality out of people with severe psoriasis. Interestingly enough, the mortality rate is, not the mortality rate, the incidence is highest in Norway, with incidence of 8.5% in adults, and it's more frequent in countries which are further from the equator, which I thought was kind of interesting. So there are 5 different types of psoriasis. There's psoriasis vulgaris. This is usually what people think of when they think of psoriasis. This affects about 90% of people with psoriasis. Next is guttate psoriasis, which is characterized by drop-like looking lesions. Erythrodermic psoriasis, characterized by red splotches. Inverse psoriasis, which often occurs in folds, like behind the ears, under the armpits, in the genital creases, things like that. And pustular psoriasis, which is characterized obviously by pustules. So, diagnosis of psoriasis. When a medical professional is diagnosing someone for psoriasis, they need to examine the skin, nails, and scalp of the characteristic skin condition, which you can kind of see on the right there. And then some symptoms include itchy skin, nail pain, and also some joint pain. So you can develop a form of arthritis called psoriatic arthritis from psoriasis. Other indicators of psoriasis, since it could be a genetic disease, are a family history of psoriasis and any recent lifestyle changes. But to make sure that the patient does in fact have psoriasis and not any other type of skin condition, if you're not 100% sure, it's necessary to take a skin biopsy, send that to a lab so that you can get an accurate diagnosis. So a little bit about the mechanism to how psoriasis, affects the body. It's not entirely clear, but I'll go through what we do know. So some antigen activates Langerhans cells, and these cells move from the skin to lymph nodes, and they present some type of antigen to naive T cells. And then these T cells are activated by these different pathways. It causes reactivity with these autoantigens, so antigens in your own body, through molecular mimicry. Once these T cells are activated, it causes a secretion of a bunch of different cytokines, which I have listed there. Most of them are pro-inflammatory. And then this causes, as I was saying, a hyperproliferation of keratinocytes, causing those skin plaques as your skin just basically replicates out of control. And as I was saying, this disorder is potentially genetic. There's a concordance rate of 63 to 73% in identical twins, and then a concordance rate of 17 to 20% in non-identical twins. And the presumed gene which is susceptible to the disease is PSORS1, PSORS9. So B cells don't play a huge role in psoriasis. It's not studied very much, but B regulator cells suppress psoriasis-like inflammation by T regulator expansion and the inhibition of Th17 differentiation. And also B regulator cells regulate early stages of psoriasis. For T cells, there's a little bit more of a role. So dysfunctional T helper cells cause psoriasis. So T helper 1, T helper 17, T helper 22, and T reg cells. When these are dysfunctional, it causes them to secrete various cytokines, which again are pro-inflammatory. And like how the B reg cells regulate early stages of the disease, T reg cells are going to regulate late stages of the disease. There's various receptors that are associated with psoriasis. In mice models, deletion of receptors such as IL-17RA and IL-36R have been shown to alleviate psoriasis conditions. And also, different receptors are associated with the cytokines. Those are pro-inflammatory cytokines, which the T cells are releasing, such as IL-17RA, TRA, F6, IL-36R, etc., etc. A few innate cells that are involved in psoriasis. So it's been found in psoriasis patients that there are increased amounts of ILC3 cells in psoriatic lesions and blood samples. These ILC3 cells produce a cytokine called IL-17, which is highly related to psoriasis, and that hyperproliferation of keratinocytes and just various inflammation in psoriasis patients. There's also increased amounts of gamma delta T cells in psoriatic lesions. Gamma delta T cells, unlike alpha beta T cells, do have some innate cell properties, and these are also going to be producing that cytokine IL-17. And then also there are increased amounts of natural killer cells in psoriatic lesions, and after treatment of psoriasis, there are decreased amounts. So speaking of treatment, there are a few different treatments you can do for psoriasis. There is no cure, unfortunately. But there are various palliative treatments, such as topical medicine, systemic medication, so different types of medication which affect the entire body, and then also light therapy, which uses specialized light bulbs or lasers. It should be known there are various light therapies on the market that you can do by yourself at home, but everywhere I read, it said they recommend that you get professional care when using light therapy. So the current research, as I was saying, the mechanism of psoriasis, it's not entirely understood. Something that I thought was interesting is the gut microbiome is under investigation. There have been a couple of different strains of bacteria which potentially dysfunction in those colonies of bacteria has led to psoriasis. And also there's the development of new treatment options, such as biologics for psoriasis. Biologics are just different medications which have components of animal or human or bacteria-like components. And that's everything, and here are my references, and I hope you enjoyed it.